Well, the Balanced Budget Act of 1997 basically provided a solution to a major problem that we're facing in rural communities across the United States. And that major problem was the closure of hospitals, particularly our rural hospitals. And in essence, what it did is it created a new type of rural hospital that was specifically designed for rural communities and rural people.
In the 1990s, the Finance Committee worked together in a very bipartisan manner, but we were also conscious of costs. So whenever we had a proposal that we wanted to bring to consideration of the committee, we were always asked, who's your Republican co-sponsor? I worked for a Democrat, so it was always like, who on the other side of the aisle supports this proposal, and how are you going to pay for it? And so at that time, while we were looking to reduce federal spending, we also knew that was an opportunity for us to help our rural hospitals and rural healthcare providers. And that was the way most legislation was enacted coming out of the Finance Committee.
We had some very wise people, some inside the State Office of Rural Health, some inside the federal government, some at state level.
So what the government said is, we're not going to make a wholesale change right away. Let's start some demonstration programs in a variety of states across the country and see if we reimburse on a cost basis. That would allow facilities to operate as they were, and can we in turn get them to be providing the kinds of care and services that we want.
Colorado had some early lessons that indeed this was a viable model. So we were sort of an early adopter and one of the first to come on board with our rural health plan and then the critical access hospital.
The Critical Access Hospital program was by far away the most important program that was included in the Balanced Budget Act of 1997.
Many hospitals saw that there was a benefit to this. There were some that were small at that point. Some had a lot of unused capacity, and so it wasn't that big of a shift. But there were others that had 35, 40 beds who realized, we're going to squeeze down to the 15-bed limit with 10 extra swing beds. It makes sense economically to do that, and also in terms of meeting the needs of the community.
And so I think the whole process of becoming designated forced hospitals and their boards to examine what was most precious and feasible for that community.
I have never, in my 5 years working with the federal government, I have never seen a program, whether it's USDA, Economic Development, Commerce, or whatever else, that allowed the flexibility that the funding through the BBA. So on one hand, we were cutting costs, and on the other hand, we added a new program. Pretty amazing. And what was amazing was, as the title says, it was flexible.
I invited 10 or 12 people to a meeting and chose those people very carefully. There were some researchers, some state office directors, hospital administrators, AHA was there. We were going to talk about how to design this program as if it was the private sector. And we just talked it through and visioned how this program could work for the state offices, work for the feds, work for these small rural hospitals, now CAHs, how we could do our very best to save these hospitals. And that's really what Flex was all about. It was saving small rural hospitals.
And so the Flex program gave the State Office of Rural Health and partners some money to make that technical assistance to help with that process and support, thereafter. It would have been difficult for the state to make that investment, so it was very important.
I think the Flex program is necessary because side by side with getting hospitals converted over to critical access hospital status, there really was a need, first off, to do community needs assessments to understand what were the true healthcare needs of the population that the hospital could meet. And we're saying a lot of the work and the revenues for critical access hospitals don't come from the inpatient side, from staying overnight, but really from the outpatient side and from prevention and wellness activities in the community. And those needs assessments help make that linkage between the local hospital and what services were essential to that local community.
Rural hospitals and rural health issues were very important to many members of the Senate. In particular, members of the Finance Committee, which because of its jurisdiction, which had jurisdiction over the Medicare program, a lot of effort was focused on improving Medicare for rural areas.
I'm extremely proud of the Office of Rural Health Policy for their vision and allowing the flexibility not only of the Flex Grant that created critical access hospitals, but also the initiatives that they've put out, the educational models that they put out so that state offices of rural health could grow.
It's really pretty clear that without the Balanced Budget Act, without critical access hospitals, hundreds and hundreds of rural hospitals would have closed. It did create this new financial model. And in that new financial model, we saw a significant decline almost immediately in the number of rural hospital closures. So for purposes of rural health and for rural folks, the fact that it was able to stop the closures was really very significant.